I'd like to welcome all our participants to today's webinar. The Antimicrobial Stewardship Project webinar series was created by the Center for Infectious Disease Research and Policy at the University of Minnesota. I'm Dr. Marty Peterson. I'm your host and the outreach coordinator for the project. We are pleased to have with us today Dr. Barbara Vanderpool to present her webinar, as you can see from her beginning title slide here, Resistance-Guided Therapy for Mycoplasma genitalium, Application of Macrolide Resistance Testing Results. Dr. Vanderpool has her PhD and Master's in Public Health, and she's a professor of medicine and health behaviors at the University of Alabama at Birmingham. She's also currently serving as the president of the American Sexually Transmitted Diseases Association. She's the chair of the North America branch of the International Union Against Sexually Transmitted Infections and the president-elect of the International Society for Sexually Transmitted Diseases Research. She's been involved in laboratory-based epidemiologic and behavioral research in the field of sexually transmitted infections and HIV for more than 35 years. So she's an esteemed expert to be speaking with us today, and she has extensive experience with the development and evaluation of molecular diagnostic assays, technology transfer, and capacity building, and the implementation of new service provision strategies. Before we begin and I hand it over to Dr. Vanderpool, a few instructions to our attendees today. At any time during the webinar, you are encouraged to submit your questions or comments to Dr. Vanderpool via the chat box, which you'll find in the lower right hand of your screen. So please do that throughout the webinar, and we'll address your questions either predominantly at the end, but if Dr. Vanderpool wanted to stop and address them, she can do so. And at the end, we will have time for further comments and questions. And just to remind everyone that the webinar is also being recorded, so if any of your colleagues missed it, feel free to share it with them, as we will be posting it to our YouTube channel after the webinar. So with that, I'd like to welcome Dr. Vanderpool to begin her webinar today with us.
Well, thank you for that kind introduction, Dr. Peterson. I am going to be focusing on Mycoplasma genitalium, but for those of you who don't necessarily have a burning interest in this particular pathogen, I think many of the lessons that we're going to discuss and that we can learn from management of this infection can be applied to others, particularly in that arena of antimicrobial stewardship. So I hope there will be something of interest for most of you. I will start with a disclosure slide where I will show you that I'm heavily involved in a lot of research that pertains to evaluation of new diagnostic products, new treatment strategies, so on and so forth. But I also consult with the FDA, NIH, and I have consulted with the CDC for many years in technology transfer and capacity building. So today I'm going to focus on, again, Mycoplasma genitalium, and we'll go over the epidemiology for any of those of you who are not intimately familiar with this bug. And then we'll talk about treatment and diagnosis, and then using diagnostic results to guide treatment. And I know that sounds a little like, of course we use diagnostic results. 70% of all medical decisions are based on laboratory results, so this should be no exception. But I think we have new options and new strategies for using molecular tools in different ways, and that's what I'm going to focus on. So let's start with the epidemiology of the organism. So here's a nice little picture of Mycoplasma genitalium. It's an interesting organism because it was actually the smallest free-living life form that has yet been discovered. And as such, it was one of the first genomes that was fully sequenced. And scientists are very interested in this organism in learning what are the actual minimum set of requirements for what we call life. So I think that's kind of interesting. This is a molecute, and it was first isolated from two men in 1981 who presented at a gum clinic in the UK with urethritis. It is flask-shaped, as you can see here, and it has an appendage that looks somewhat like an elephant's trunk, and that's its adhesion mechanism. And it can adhere to red blood cells, white blood cells, sperm, epithelial cells, and other materials in the urogenital tract and rectum. There is some antigenic variation in this adhesion protein, MGPA, and that's important because that was one of the first targets for lab-developed molecular diagnostics. This organism obviously has immunogenic proteins, and it can elicit a pro-inflammatory cytokine response, which is why it is a discharge-causing disease. So our knowledge of the transmission dynamics of Mycoplasma genitalium are very limited. Because this is a disease that's often asymptomatic, we don't have good information about the time of exposure or the onset of infection. So when we find Mycoplasma, it could have been there for days, weeks, months, or even years. So it's quite difficult to understand exactly what the natural history of the organism is. But more than a decade ago, my research group in Indiana at the time was following women longitudinally, adolescent women aged 14 to 17 for up to 8 years. And we collected weekly self-sampling from vaginal swabs and daily diaries of sexual behaviors. And we also collected samples from their sexual partners whenever those partners were willing to enroll in the project. So once we had a laboratory assay available, a lab-developed assay that we could use to look at Mycoplasma genitalium, we took samples out of the freezer from these young women's visits, and we found that about 14% of these women tested positive for Mycoplasma genitalium. And it wasn't necessarily associated with symptoms. And we were testing these people for gonorrhea, chlamydia, and trichomonas, and they were being treated for those infections. So it's important to note that they had Mycoplasma genitalium, even though they might have been tested and or treated for other STIs. The positivity among sexual partners was much more common if the woman had Mycoplasma than if she didn't, such that nearly a quarter of the men who were partners to women with Mycoplasma were positive as well, or only 2.8% of the men who were partners to Mycoplasma negative women were positive. And this was strongly significant. And this was in fact one of the first studies that was done to really clearly demonstrate sexual transmission. We all suspected that it was sexually transmitted since it's found in the genital region, but this was the first study where people actually were able to look at sexual partners and prove a difference in risk among those sexual partners. A recent study from Australia has shown similar data with nearly half of women, about a third of men who report sex with women only, or MSWs, and 42% of men who have sex with men were positive for Mycoplasma genitalium when they came into the clinic saying that they were a contact to a person who had been told they had Mycoplasma. So those are numbers that are fairly similar to what we see with chlamydia contacts and gonorrhea contacts when they come into the clinic. About these proportions are positive for those infections. So within dyads, though, as part of this study, they also did look at dyads, and within those dyads, they found concordance among heterosexual dyads of about half, and a little over a quarter of the men who had sex with men had both partners within a dyad infected with Mycoplasma. So it's very clearly within sexual contacts that we see this infection. So we know that it's sexually transmitted. We don't have really great data about the prevalence in the general population for a couple of reasons. First of all, we didn't have good diagnostics for many, many, many years. So access to good diagnostics is relatively new. Second of all, this is not a notifiable disease in the US. So unlike chlamydia and gonorrhea, we can't really look at the rates over time in different populations. But some of the studies that are intended to be nationally representative studies do have data that we can look at and try to understand. And what you'll see is the Mycoplasma prevalence, which is shown in blue for both men and women, is often very similar to the chlamydia prevalence, or it's lower. So what you saw in Denmark, for example, is that the rates of Mycoplasma are quite a bit lower than in men or women, but almost every other setting where this has been looked at, the rates are very similar to those of chlamydia. So if you start working with a population and you're asking yourself, is Mycoplasma potentially a problem, just try to understand your chlamydia rates from that population, and that will give you a guide to whether or not Mycoplasma is likely there. In men, we know that the prevalence in populations that are at risk for STI, so people attending STI clinics or people seeking family planning services, et cetera, ranges from 5 to 15%. And in this study that I'm showing you over in the pie chart, about 10% of men who came in with urethritis and had a microbiome assessment of all the organisms that are in their genital tract had mycoplasma. So that's really interesting because this is a nice way to look and say, even if we're not targeting one specific pathogen, we find mycoplasma in about 10% of men with symptoms of urethritis. This was recognized as a cause of urethritis, again, when it was initially isolated in the early 1980s. But many microbes play a role in MGU, which is very similar to bacterial vaginosis. And in fact, in this pie chart, you'll see that Gardnerella vaginalis plays a role in these men with urethritis as well. So there's a lot that we don't know about urethritis, but we do know that mycoplasma is fairly common. Mycoplasma is often found among men who have sex with men who present with proctitis. And in fact, when you are working with populations of men who have sex with men, we see that the anal rectal samples have much higher positivity rates than the genital samples that we usually test with male urine. So if you're serving a population of men who have sex with men, it's quite important to test the rectum. In women, again, the prevalence in settings that are at high risk for STDs, such as STD clinics and family planning clinics, contraceptive clinics, so on and so forth, range from about 9 to 12%, which is similar to chlamydia. Also similar to chlamydia, about 70% of women have no symptoms. This is really important because we need to understand the impact of asymptomatic infection. Women are more likely to have symptoms if they have common co-infections with other STIs. So we're not clear if the mycoplasma is driving those symptoms or if it's actually the other STIs. But this is a key point for screening recommendations all over the world, is none of us really understand what we need to do about asymptomatic infection because the antimicrobial stewardship outweighs what we know right now about potential risk of asymptomatic infection, which may just be carriage that's subclinical. Untreated infections may persist though, and so we need to have, again, more data so that we can understand better what the risks are for people with asymptomatic or symptomatic infections. And among women who had PID when they were positive for mycoplasma, if they were tested 3 to 6 months later, they often had, a quarter to half of them had recurrent or persistent mycoplasma infection. Women with pelvic inflammatory disease actually do have mycoplasma positivity, fairly common. These are data that come out of Maria Trent's group at Johns Hopkins University, where she finds that testing for chlamydia, gonorrhea, even including trick, doesn't tell the whole story with PID. And so treatment for PID now needs to include measures to think about curing Mycoplasma genitalium. And I've listed here a review article that's very useful for any of those of you who are interested in the clinical manifestations of Mycoplasma genitalium. And this review article in the Journal of Infectious Diseases is part of a supplement that focuses exclusively on Mycoplasma genitalium, the organism, the infections, treatment, and so on. So if you have an interest in learning more about it, I would highly recommend both that article and that supplement. But in a meta-analysis reported in that article, they show that cervicitis, pelvic inflammatory disease, and preterm birth and spontaneous abortion as well, are all statistically associated with the presence of mycoplasma. So we have data about epidemiologic association. What we don't have are data showing that treatment avoids these consequences. And we don't have data that shows that these consequences happen just as frequently in the absence of co-infection. So there's more work to be done, and so there are gaps in our current knowledge. We don't understand the importance of asymptomatic infection. We do know that women with PID and men with proctitis often have MGen, but we don't know if they were symptomatic before they developed PID or before they developed proctitis. And so we don't know if asymptomatic infection actually leads to those downstream consequences. We also don't know the importance of co-infection, and we don't know if MGen plays a facilitation role or plays an independent role in the process of other STIs that are related with the same outcomes. So I mentioned that we don't know much about co-infection, but one of the things that we do know from this really fascinating study where they looked at chlamydia, gonorrhea, mycoplasma, and trichomonas, which just is not done very frequently, what they saw from these data was 10 to 12% of genital discharge is associated with mycoplasma co-infections. So co-infection is an important factor in people who have symptoms. About a third of the MGen infections in women have co-infections with other STIs, and about a quarter of the MGen infections in men have co-infections. So it's really important. But you can see in the reddish pie chart down at the bottom about women have 25% of the women had mycoplasma only. So it's significant in and of itself when it's associated with symptoms, but 31% of the men had mycoplasma only. Again, a significant number. So these are from people with non-gonococcal urethritis and cervicitis, so that's why the gonorrhea rates are so low. So let's talk about how we should approach treatment for this infection. So beta-lactams and sulfa class drugs do not work against mycoplasma. We need to either inhibit the bacterial protein synthesis mechanisms with macrolides and tetracyclines, or we need to use quinolones to inhibit bacterial nucleic acid synthesis. So these are what are available in the US. We don't have many options, but we'll talk about what people are doing in other places around the world where there really aren't a lot of other options either. So macrolides, predominantly azithromycin, have been the class of drug used most often to treat MGen infections, but macrolide resistance has been shown to be associated with mutations on the 23S ribosomal RNA gene of Mycoplasma genitalium. We've also seen declining cure rates with azithromycin regarding mycoplasma treatment in areas that have heavy azithromycin use. So if you're working in an STD clinic population where the mycoplasma rates might be as high as 10 or 12%, that's also a population where empiric treatment for chlamydia is often given for people with NGU or cervicitis while they're waiting on test results to come back. So in those populations, azithromycin is given out to a large number of people who may have mycoplasma infections. And because we've seen a lot of that, we're seeing a lot of resistance in those populations. But remember that it's not just stewardship in an STD clinic setting, but it's antimicrobial stewardship in all settings, because in populations where Z-Paks and azithromycin in other formats is used for a number of non-STI treatments, again, we see high rates of macrolide resistance in the specimens that we're detecting with mycoplasma. So here's a study that I think was particularly useful at demonstrating our concern in this particular area. And the study was focused on treatment of non-gonococcal urethritis. It wasn't a mycoplasma-driven study, and it was by Lisa Manhart's group out of Seattle, Washington. And they looked at a number of bugs, including chlamydia, mycoplasma, ureaplasma, and then what they categorized as idiopathic infections. And they provided data both about the clinical cure and the microbiologic cure. Now, the clinical cure is defined by a cessation in symptoms. So when the person comes back for the follow-up visit, they report that they're not having any discharge, dysuria, pelvic pain, etc. Microbiologic cure is a bit of a misnomer. It should say molecular cure. We all still kind of have trouble wrapping our heads around that. But remember that we're not isolating organisms, and so we can't say anything about viability. All we can say is that we detected the DNA. So DNA shedding may or may not be associated with some of our outcomes, and we need to keep that in mind. But that said, they randomized this patient population to either receive azithromycin or doxycycline. Azithromycin, 1 gram single dose, or doxycycline, 100 milligrams twice a day for 7 days. What you see here is that the clinical cure rate is not very good for azithromycin, but it's much worse for doxycycline. So 63% clinical cure rate for azithromycin is not very good at all. And what you'll also notice is that the clinical cure rate, so the cessation of symptoms, is much higher than the molecular cure rate. So then that should have us questioning, is that molecular cure rate super meaningful? Because just because we can detect the DNA, if the symptoms haven't resolved, are we worried about that patient? Do we need to follow that patient more, and do we need to continue testing and or finding treatment solutions for that patient? And these are questions that are completely unanswered at this time. And if you look at other places around the country, what you'll see is that in those places that have done small independent studies, the range of macrolide resistance goes from about 44%, which was seen at the STD clinic here in Birmingham, Alabama, where I work, up to about 95%, 94% among men who have sex with men living in Seattle. So you see a huge range. And again, this is the 23S ribosomal RNA gene mutations, but just a huge range of resistance rates. But we don't really know just from this what the meaning of those resistance rates are. So now thinking again about fluoroquinolines instead of macrolides, fluoroquinoline resistance in Mycoplasma genitalium has been associated with mutations on both the GRA and the PARC genes that include gyrase A and topoisomerase. And these mutations have actually been linked with clinical outcomes. It's a very small study, but these are the types of studies that are really critically important to our understanding of all molecular and genetic resistance markers, and we need clinical outcomes data associated with those. So in this particular study, all of the patients, but there were only 6, with PARC mutations failed moxifloxacin, while only 3 of 48 failed moxifloxacin and didn't have the PARC mutation. So of course this was highly significant. We need to continue to do studies like this in other settings to confirm these data, but this is strongly suggestive that these genetic markers are meaningful when we're thinking about patient outcomes. From a study of a little over 300 men who have sex with men and are living with HIV here in Alabama, we had 27 men that were positive for mycoplasma. And when we looked at the resistance profile for those samples, what we saw using 23S RNA target for macrolide resistance markers and sequencing for the fluoroquinoline resistance markers, we saw that 70% of the urine specimens had resistant samples, but 80% of the anal samples were resistant. And you see the same pattern then when you look at fluoroquinolines and when you look at multi-drug resistance. So you always have higher rates of resistance in the anal rectal samples. And in fact, when you look at positivity rates, you see higher positivity rates in the anal rectal samples. So very much like chlamydia and gonorrhea, among men who have sex with men, we really need to be focused on testing at sites of exposure. The other thing that I think is really disturbing is to know that 20 to 30% of all the samples that we had multi-drug resistance. So this leaves us, scratching our heads and saying, well, what are we going to do and where are we going to go with this in terms of treatment guidelines? So unfortunately, the last guidelines that we have from the CDC here in the US are from 2015, and so many of these data are much newer than that. But the new version of the CDC guidelines is in development just now and is anticipated to be released in about April of next year. There's currently no screening recommendation. And what I mean by that is there's no recommendation to test asymptomatic people. So unlike chlamydia and gonorrhea, there's no recommendation for screening younger people or screening people that are in high-risk settings but are not exhibiting symptoms. So this is really intended as a diagnostic test at this time, and the CDC recommends using molecular methods, because we'll talk a little bit about diagnostic methods in a minute. And the CDC currently recommends only testing for Mycoplasma genitalium among people who have persistent or unresolved symptoms. So currently the strategy is a person comes in with NGU, they're treated per standard of care for NGU. If those symptoms don't resolve and they come back, at that time you can test for Mycoplasma genitalium. And if they receive something other than azithromycin for their NGU, their first line at this repeat visit would be azithromycin. If they've already had azithromycin, or if symptoms continue to persist after another week, then they can go to moxifloxacin 400 milligrams for 7 to 14 days. But you can see that this would involve a patient being actively involved with the clinic and changing treatments for a month. So this is clearly not ideal management for these patients. It's frustrating for patients, it's frustrating for providers. But it was based on the best data that were available at the time these were written. Now, outside the US, they have a little bit different process, and they can respond to newer data a little bit more quickly than we can here. And in 2016, there were already data that were becoming available that were included into the European guidelines, where they recommend testing men with symptoms of urethritis, women with mucopurulent cervicitis, or if they have abnormal discharge and STI risk. So not all women with abnormal discharge. But on the other hand, most women with abnormal discharge probably have STI risk, so that one's pretty simple. If the patient is macrolide resistant marker negative, so in 2016, in Europe, they were already having an expectation of getting a macrolide resistant result with their diagnostic result for mycoplasma. Treat the patient with azithromycin 500 milligrams on day 1, 250 milligrams days 2 through 5, so a total of 1.5 milligrams over 5 days. There have been several independent studies and one meta-analysis that all pretty much concur that the data don't support 1.5 milligrams over 5 days over 1 gram single dose. They don't show any difference in efficacy, but that's what's in the guidelines right now. And for people who have MGent and are macrolide resistant marker positive, they should be treated with moxifloxacin 400 milligrams 7 to 10 days. So those are the current 2016 guidelines in Europe. In the UK, the British Association for Sexual Health and HIV, BASH, released new guidelines in 2018, and these expanded the recommendations a bit. And with these, they recommend testing men with symptoms of urethritis, epididymitis, or proctitis, and women with cervicitis or PID. And they've taken out the STI risk requirement. Again, for those who are negative for the mutation for macrolide resistance, doxycycline for 100 milligrams, 2 times a day, 7 days, followed by azithromycin 500 milligrams day 1, 250 milligrams days 2 through 5. So again, this 1.5 milligrams over a 5-day period, but it starts after a week's regimen of doxycycline. For people who are macrolide resistant positive, treat with moxifloxacin 400 milligrams 7 to 10 days. So no different than the European guidelines. So that's going to get us into diagnostics so that we can talk a little bit about how we can get data to support the guidelines. First of all, the only reason that I'm going to mention culture, because it's quite difficult, is because it's currently the only way that we have of establishing minimum inhibitory concentrations of antimicrobial sensitivity. But it is so fastidious that the organism has to be grown in co-culture with tissue culture. And then once the organism is grown enough that isolates can be pulled from that tissue culture system, they can be subsequently adapted to broth culture. But this can take 3 to 6 weeks to have a diagnostic determination, which is clearly unacceptable. Culture also only has about a 20 to 50% sensitivity. So what this tells us is that if this is the only way to establish MICs, that we probably need to look for a different technology to use rather than MICs when we're evaluating new treatment strategies. Lab-developed tests first became available on molecular-based test or nucleic acid amplification test, NATs, in the early 90s. And these are targeting, the first ones targeted the MGPA gene, which I told you is the gene that encodes for that protrusion that looks like the elephant's snout. But there's variability in that gene, and that made these a little bit difficult to have consistent results for. But it was such a huge step forward from culture and culture's insensitivity and just absolutely massive manual technological requirements that this allowed a broader understanding of the epidemiology of this organism by collecting surveillance data. These tests were eventually validated in many laboratories for use as patient management diagnostic tests. But there are problems with lab-developed tests, and these include DNA extraction, which is predominantly done with MagnaPure or some similar type technology, but can suffer from massive inefficiencies and operator-to-operator variations. primer and probe reagent quality, which can vary substantially between lots. And these are predominantly manual assays, and so they involve all the concerns that we had with molecular assays for diagnostics when we first started using them for chlamydia and gonorrhea. Tests became commercially available, obviously, outside the US before they were available here, but we're starting to catch up. The Hologic Aptima-MG assay is an RNA-based assay, which was available for more than a decade as an analyte-specific reagent. And so that's something that even though the laboratory has to validate this assay locally, the reagents are quality assured and the system and process is automated. So that actually reduces a lot of variability and increases confidence in diagnostic results. But it doesn't matter because we've gone even further than that, and this has been approved for the FDA, by the FDA in 2019, and several specimen types are cleared for use with this assay. So this assay can be used routinely any place that's doing hologic aptima testing for chlamydia, gonorrhea, or trichomonas. Roche released their cobas trichomonas mycoplasma real-time PCR assay this year as well. That runs on their cobas 6800, 8800 platform, which also can do chlamydia and gonorrhea testing. So again, with both of these two assays, you now have opportunities for routine clinical diagnostic laboratories to run these tests without a lot of internal validation, and they can be run with samples that are already being collected for chlamydia and gonorrhea testing. Now, this is where we need a word of caution about bundling, because while it's nice to think about having one specimen and we can run 4 tests on it, those 4 tests might not always be appropriate. So for example, if you see a woman and you're screening her because it's her annual visit and she's under the age of 25, testing for mycoplasma is probably not appropriate, which is fine because in both cases, these tests you order what you need, and so it's not required bundling, but we just need to make sure that laboratorians and clinical providers are really communicating well about what tests are available and when it's appropriate to use those tests. But there is a new assay on what I call the immediate horizon, and by immediate horizon, I mean that this assay has already got a CE-IVD mark, so it's cleared for use in Europe, and it's currently under evaluation in the US. And this is the SpeedX Resistance plus MG assay with Plexzyme chemistry. Now, I'm not going to talk in any more detail than this about this particular assay and why it's different and why it works the way it works. But if you Google Plexzyme and you're interested in that type of chemistry and technology, you will be able to see all kinds of diagrams and demonstrations about how it works and why it's different. But from a clinical perspective, what's really important is that the results have an added feature, and that is the Macrolide Resistance marker. So the results that one would get with a routine specimen sent for mycoplasma testing would be mycoplasma negative or mycoplasma positive macrolide resistance marker negative, or mycoplasma positive macrolide resistance marker positive. So now this allows us to have immediate information that can be used to appropriately target treatment based on the organisms found in that patient. The assay is interesting in that it's platform agnostic. In other words, you can put it on any platform that you have that performs DNA extraction and can do real-time PCR. So one of the nice things about it is there have already been studies, and in fact, the assay has a CE-IVD mark clearance for use in Europe on the Cepheid Gene Expert system. So in this particular case, because it's a cartridge-based system that integrates DNA extraction with the amplification detection process, you can insert the specimen into a Cepheid cartridge, and in 90 minutes you can get your assay result. And again, the result has got the macrolide resistance marker information with it. So that's a really great opportunity in places where we need a test result much faster than sending it out to the laboratory. So now how do we want to take these data and use them? And this is the crux of the issue. This is the resistance guided therapy piece. Well, the first thing that we need to do is we need to say, okay, if we can look at these data, can we correlate these data to clinical outcomes? Is there clinical utility to knowing this information? And again, most of the good data on this come from Australia and from this really great study done by Besesser and colleagues They found 155 patients that had mycoplasma, and of those, 99 were negative for the resistance mutation, and 88 of the 99 responded successfully to azithromycin. Well, that's even better than what we saw in the study with NGU, where only 68% of people responded to azithromycin. So that's a pretty good cure rate. But what's really disturbing is the 11 patients who failed azithromycin therapy, when a sample was taken post-treatment, they now could detect the macrolide resistance marker. So this implies that those patients had very minority populations of macrolide resistant organisms, and that the azithromycin managed to remove all the organisms that were macrolide sensitive, but enriched for that population of organisms that was macrolide resistant, and that's what the patient was now dealing with. So that's quite concerning. So even knowing that they don't have the resistance marker doesn't guarantee that that will be the case after treatment. Among those people who had the mutation, only 7 out of 56, or 12%, responded successfully to azithromycin. So obviously, the mutation is a very good predictor of azithromycin failure, because people who had the marker were 50 times more likely to fail. So that led to the Australian guidelines that are currently in use in that country. And so men with NGU or proctitis and women with PRD should be tested for mycoplasma. A sample should be collected at the initial visit for mycoplasma testing, and at that initial visit, the patient is given doxycycline 100 milligrams twice a day for 7 days. And then a follow-up is scheduled for the next 7 to 14 days. And at that time, they review the lab results so that they'll know the macrolide resistance status in the patient. If the person was initially mycoplasma negative, if they have any other STDs, like for example, trichomonas, that wouldn't have been treated by the doxy, they should be treated for those infections. And if their symptoms have cleared up and they have nothing else, you know, they're finished with their treatment strategy. But for those people who have mycoplasma positive, if they're mutation negative, they'll be treated with azithromycin 500 milligrams for 5 days. Now this is increased from 1.5 to 2.5 milligrams over a 5-day period. Again, there aren't strong data in the literature that show that this is an improved treatment strategy, the azithromycin increased dosage. But since there was no improvement with 1.5 milligrams in Australia, they decided to try 2.5 milligrams. If the mutation is present, they're treated either with citalfloxacin, which is not the commonly used treatment, or moxifloxacin 400 milligrams times 7 days. So it's this 2-stage process where patients are given doxycycline for 7 days and then another drug based on their mutation results and improvement. Well, there have been 3 really telling studies, and you can see that all of these are from 2019, and one of them is actually from an abstract that was presented this year at an international STD research meeting that hasn't even made it into the full publication yet. So these are kind of cutting edge data, again, all from Australia. So first, among 47 women with PID, cure rates were above 90% for all women. Remember that for the NGU study that Lisa Manhart group did in Washington in the US, they found only a 60 to 70% cure rate for NGU. So these 90% cure rates pretty awesome. Among 80 women, 160 men who have sex with women, and almost 200 men who have sex with men, in the original pre-treatment analysis, over 70% of these people were positive for macrolide resistance. So again, those resistance rates are just increasing in the population in general. But this 2-stage strategy resulted in 95% cure rate for people without the mutation and a 92% cure rate for people with the mutation. So those are really excellent cure rates. And finally, the 244 people, 68% of them were positive for the mutation. And again, the cure rates were around 95 and 92% for people with and without and with the mutation, respectively. So I would argue that the 2-stage treatment is a very clear improvement. And so I think these are data that we'll be looking at here in the US as the CDC is developing its next round of guidelines. But I think it's important when we think about these things, why does this work? So doxycycline, if you'll remember the study that I showed you where they used azithromycin and doxycycline cure rates were only in the 40% range. So it's not a highly effective drug against MGen. And here we see a compilation in the chart on the right of studies that were looking at NGU and compared both doxy and azithromycin. And you see cure rates for doxy in the 30 to 45% range. So really, doxy is just not that effective. We've also heard reports of diminishing azithromycin effectiveness. And if you look at these studies that are in the bar chart, what you see is between 2009 and 2013, you see really decreasing rates of susceptibility to azithromycin. So patients can enrich for the mutation positive strains after azithromycin. So again, these cure rates of in the 90% are pretty astonishing. So why do we think that's working? Well, they looked into this with the population that they're following in Australia, and what they found is that after that 1 week of treatment with doxycycline, they saw a 2-log decrease in the organism load. And so the current thinking is that that decrease in organism load allows that second stage to be more effective than it could have been if it was fighting the entire population in the patient's system to begin with. And I'm going to end with just one slide about point of care testing. I mentioned that the SpeedX assay that does provide macrolide resistance information for the practitioner can be done on the Cepheid instrument that takes 90 minutes. And do we really need that, and do we really care? And I would argue that there are some people that I think that this really makes sense for. And when you have symptomatic people, rather than waiting that week for results and then coming in at day 7 to 14 to determine if you get azithromycin or moxifloxacin as your second drug, people would know right from the get-go, I'm taking doxycycline for a week, and then I'm taking either azithromycin or moxifloxacin for the following week. And this might be impactful for those people who don't come back for that follow-up visit at 1 week, because we know that doxycycline is not really an effective cure in and of itself. So we really need people to get into that second stage of treatment. Further, when people come in as contacts to Mycoplasma, we've seen that the concordance rate between contacts and their sexual partners is only around 45% or so. We don't want to treat 55% of people who are MGen negative. So having a diagnostic result right away and knowing exactly how to manage that patient would be really helpful in that setting as well. So I'm going to leave you with a few take-home messages. In many respects, Mycoplasma genitalium is similar to chlamydia, with both prevalence in the general population and in high STD risk populations. It's similar based on the fact that symptoms for chlamydia and symptoms for Mycoplasma are often the same: discharge, cervicitis, pelvic pain, dysuria, but also lack of symptoms in huge numbers or huge proportions of women and large numbers of men, and particularly lack of symptoms for rectal infections, are the same between chlamydia and Mycoplasma. And complications of untreated infections look to be very similar between these two infections. Co-infection of Mycoplasma with other treatable STI is common, and so we really need to make sure that we're testing people for multiple pathogens, not just a single pathogen. But that said, it's really unclear what to do about asymptomatic infections. And if we don't know that we want to treat them, then we certainly don't want to test them, because if people access their results and see that they have a positive result and ask if they were treated and their provider has to say, well, no, that's going to be an uncomfortable conversation. Antimicrobial resistance is common, especially macrolide resistance, and it's increasing very quickly. It has evolved even in just like a 2-decade period. And azithromycin is no longer useful as a single drug therapy at all. And resistance to fluoroquinolones is increasing. So when Australia first started using something more similar to the European guidelines, where they went directly to moxifloxacin for those people who had the macrolide mutation, that found those people started developing the fluoroquinolone mutation as well. guidelines really need to be flexible and evolve rapidly in order to keep up with the data that are being generated about this infection, because it's really coming quickly and things change constantly, and that's where updates. So if you get dear colleague letters or you see updates to the CDC guidelines, you really need to look at those, because those are really the way that you can see what the current thinking is on how best to manage patients. And finally, I think that new diagnostic options are really improving our understanding of this infection, who has it, who's at risk for it, what the consequences are, and then how to manage it. And I think this is the organism for which we have the best data correlating genetic mutation results with clinical outcomes. And so I think we can feel very confident that if, for example, we have some new compound that we want to test in a treatment trial, we can use the mutation results as biomarkers of clinical outcomes in many cases. And resistance-guided therapy appears to be very effective with this dual-stage process that's currently being used in Australia. Doxycycline comes in and reduces the organism load up to 2 logs, and then follow up with azithromycin or moxifloxacin shows excellent clinical cure rates. And the nice thing about that too is that when they follow up these people that have had the 2-stage therapy, resistant organisms are not being isolated following this strategy. So we're not enriching for those subpopulations as was happening when azithromycin was being used alone. So with that, I'd like to thank you for your time and attention. And if you have any questions, I would be happy to answer them.
Thank you, Bobby, for that terrific webinar and just, cutting edge here of treatment strategies for Mycoplasma genitalium, including resistance-guided therapy. As we wait for some questions to come in from some of our attendees, you did answer at the very last bullet there my first question, which was around talking about clinical cure and the correlation with the, I guess you would call it, molecular bacteriology cure. So it appears that although they haven't been correlated in the past, that you're saying that the evidence supports the 2-stage and that they're not detecting the organism post?
That's right. So yeah, when people were using azithromycin only, the people that were azithromycin sensitive would be cured mostly, but those people who failed treatment actually developed an enriched population of resistant organisms that hadn't initially been detected. But with this 2-stage strategy, we're not seeing that. So it looks very positive that this 2-stage strategy is a way to not only effectively manage that patient, but to really keep resistant organisms from developing and being spread within the community and the population. So from an antimicrobial stewardship perspective, this is a way that we can really make sure that we're not exacerbating problems and adding to the difficulty by enriching for any one single resistance marker.
Yeah, it's a really important, very important point. And what struck me is looking at the differences across the guidelines depending on the region, the geographical region. And I know that, as you mentioned, the CDC is currently reassessing the guidelines. Are there more studies that need to be conducted before they would consider this 2-stage approach? I mean, I don't know what studies you think need to be done here to get more information.
Well, I think the only difficulty that we have right now is that all the studies have been conducted in Australia. Okay. And so, I mean, I think that anytime you have information from only one setting, and of course Australia is a very large country and isn't only one setting, and there tends to be a little more emphasis put on US collected data, which, right or wrong, that's just one of the things that happens. And so in fact, next month here at UAB, we're starting a treatment study where we will mimic the Australian guidelines, and we will follow patients 90 days, and we will look at both molecular and clinical cures. And so we will do that type of evaluation here in the US, and hopefully that will help provide additional data that the CDC might be looking for.
Yeah, that's excellent. We look forward to that information for sure once you have it to present. So some other questions that came to my mind is, current strategy, can you just talk a little bit about like the current approach in the laboratory? So right now in the United States, predominantly you're just basically looking for whether there's DNA present there, yes or no, and it's not been adopted yet so much where we're looking at the resistance markers.
So the resistance marker assay is not cleared in the US yet.
Okay.
We're hoping by the end of the year, perhaps. I mean, you can never tell with these types of things. Yeah. But the studies have been underway, and we're hoping that will come out soon. Yeah. So currently, the only thing people in the US can do is to look yes or no.
Right. Okay.
And so that makes it difficult, again, for the CDC, thinking about, you know, how do you make a recommendation for this two-stage process when people don't have all the information that they need to go into that two-stage process. Now, that said, there are numerous studies underway to take different processes and try and adapt the resistance marker assay to those processes so that people might be able to get a resistance result even before that assay is cleared. But I think that right now we're in a difficult position, because right now people weren't aware of Mycoplasma, then they were aware and they didn't have a test. Now they have a test, but now they know that they need macrolide resistance testing, and that's not quite available yet. So we're not in a really good place for that, and it's not clear what you should do in terms of ideal treatment strategy for those people who are resistant, because I don't think we want to be going moxifloxacin, you know, as a knee-jerk reaction to everybody that has Mycoplasma, because it's just going to be, it's expensive and difficult.
Right, and that was going to be my next question about the utility of then at some point having the fluoroquinolone resistant marker as well with the diagnostic.
Yeah, that's a great question, and people are working on that, because that's obviously the next thing that's going to come along. Although, you know, there's some hope that if we can stop this escalation of, you know, having resistant organisms within our populations, maybe if we can get this under control, even just knowing the macrolide resistance markers, we might be so far ahead that we can avoid more development of fluoroquinolone resistance. Right,
exactly. So right now the CDC treatment guidelines you presented and reviewed for us, and I appreciate that, there's no screening recommendation at this point. So when do people tend to screen for it?
Well, people don't screen because, and they probably should.
I guess test, I should use a different term, yeah.
So here in the US, it depends, of course, on where you're situated. And so for those of us who are in the STD arena, I think that we tend to test more proactively for Mycoplasma. But people who are in primary care settings who maybe are not familiar with it, I think that as a general rule, that's more of a follow-up test for people who have failed therapy, so, which is a bit problematic. But on the other hand, remember that these commercially available tests have only been available in the US for about 6 months. Yeah. So this is a new paradigm for us. And so to encourage people to start routinely ordering chlamydia, gonorrhea, trichomonas, and Mycoplasma in people who have abnormal discharge is a way that we will start finding out more information about who's got this, how frequent it is, so on and so forth. And then hopefully we'll have the macrolide resistance supporting data soon.
Yes.
Be able to add that to our information profile.
So it could very much change the clinical practice as these things become available, and then more data becomes available and CDC guidelines get updated. One thing that struck me—
a field in flux.
Yes, absolutely. And, you know, it's a combination, like you said, it's important for the diagnostics laboratory to communicate with the clinicians about when and what test when to order and what to order when these become available.
I think that's one of the real key points here.
Yeah. One of the early slides you presented, I believe it was like slide 10, you were looking at the Journal of Infectious Diseases 2017, the review of MGen among women, and some of the, if they were found positive to some of the other types of risk factors or co-infections or clinical symptoms that they had.
Yep.
Pelvic inflammatory disease, premature births, that sort of thing. Is this in women? I wanted to just review this. Were they symptomatic such that they were tested, or are these an ACE? I see they have cervicitis, pelvic inflammatory disease. Are they, could you tell us a little bit more about this? Because I'm getting at a question around, you know, right now not testing asymptomatic women, and I'm kind of wondering what their burden, microburden is, biological burden of it.
So these data are actually from a meta-analysis where there were several studies, and it's the one that's shown down here at the bottom, lists et al. But if you want to see the actual original meta-analysis as opposed to this review article, but this was a compilation of studies that ever looked at mycoplasma with a diagnostic test among people who had these outcomes. So understanding their level of symptoms before they were tested is not very easy, because it's not
Right.
the study was designed the same way. But
Right.
usually these are women, so it's kind of taken from a time point and looking backwards. And so they look at women who've had preterm birth, and they go back into their medical record and see if they ever had a mycoplasma result positive. Or if they have stored samples, they go back and test those to see if they can find an older specimen that had mycoplasma. So again, understanding the symptoms associated with that older sample in a retrospective chart review is really difficult.
Right. But I was tying, when I was listening to you, the asymptomatic women, and whatever that means. Do you have any idea of kind of the Mycoplasma genitalium like burden, the amount of organism there when they're asymptomatic, or is it just kind of all over the place?
We don't have good data because, again, we didn't have good diagnostic tests that allowed us to estimate organism load.
Yeah.
The newer tests, while they won't let you do it directly, for those of us who like to play with our instruments, you can put calibrators on and you can get at organism loads, but they're so new that nobody has a lot of longitudinal data on that.
Yeah.
So yeah, it's really hard to get at. We do know that symptoms are more common among those women that have co-infections, but so then you have to wonder if the organism load really matters, because if you've got two different organisms, which one had to be really strong in order to cause the symptoms? So everything is unfortunately quite complex, and so we don't have really easy answers.
Right, and it almost suggests, as there's diagnostics become available in more studies, you know, it is throughout the theme of your presentation that it's still yet unknown around asymptomatic women, or testing women at a certain age, or whatever, if there are these potential risk factors, if they would happen to have Mycoplasma genitalium. So I guess that field and that epidemiologic types of studies will just be ongoing and evolving.
Yeah, but I think that we will have an explosion of data over the next 2 to 3 years, as now we have access to these, you know, highly reliable diagnostics tools that will be able to start gathering data. I mean, we'll even be able to start gathering data from insurance claims. So for example, if you know that people have mycoplasma, and then you look at insurance claims within the next year and see if they had any reproductive CPT sorts of codes, or ICD-9, ICD-10 codes, you know, so I think that people will start doing some innovative and creative research now that we have diagnostic tools, but it's still going to be difficult to understand. The natural history of these infections that are asymptomatic and then of course are socially stigmatized is always quite difficult to come by. And so, you know, I was looking back as I was putting these slides together and realizing that I had been sort of playing with mycoplasma since 2005.
Wow.
And yeah, it's a long time ago. And I don't feel like we really know a lot.
Right. But definitely bringing it more to the forefront and understanding its role in some of these other infections and appropriate treatment. So this has just been a fabulous webinar. I really appreciate your time today. Do you have any other closing remarks before I close out our webinar?
No, thank you. I just appreciate the opportunity, and I was happy to hopefully provide some new updates.
You certainly did, and we look forward to the new CDC guidelines that will be coming out hopefully soon. So yeah, thank you. So just to close the webinar, I just want to remind our attendees that the webinar was recorded and will be available on our CIDRAP-ASP YouTube channel. I thank our presenter, Dr. Vanderpool, Bobby, for your time that you took to present the webinar and put it together for us, and thank our attendees and listeners for participating. We appreciate your support, and please feel free to send us ideas for our next webinar.